Okay, we're now going to go into the assessment. Now, just to preface, the overall objective of the wheelchair assessment is to describe the patient's medical condition and limitations and therefore justify the intervention, the wheelchair recommendations. In simple terms, when writing a letter of medical necessity, Medicare may request the assessment of the patient's limitation that the justification has been written based off of. So what that means is sometimes you go into a rehab facility, the therapist did their initial assessment, they have a full assessment that goes through all the manual muscle scores, the limitations, the range of motions. We have how far they can walk, what their gait is, how they accomplish their ADLs, and that's all documented in an assessment. And now the therapist is going to go and write a letter to Medicare saying, I know my patient because I did an assessment on them, and they require X, Y, and Z. So Medicare says, it's a nice letter. Can I see your assessment that your letter is based upon? Medicare wants objective information. They want as much information as possible for this patient. What we're trying to do here is create a picture of a patient based on their diagnosis and their limitations to give the insurance reviewer a very clear picture of how this patient is set up, how they sit, how they walk, how they transfer, what their manual muscle scores are. We want to get as much objective information as possible when we are requesting equipment. So what we do here at MyForms is we are able to put the objective information of the full assessment and then put the letter of medical necessity right next to it. So if we're going to go through an assessment, and you'll see as the assessment comes in, you'll see where we start justifying and recommending equipment, which correlates exactly to the assessment that describes the limitation. And you'll understand this as we go through the assessment. Some of the information is not as correlated back and forth, but there are certain points of the assessment you will see that we show a limitation, we recommend something. We show a limitation, we recommend something. So let's go straight into the assessment, and we'll go through each option on the assessment as we go through, and you'll get a great idea of what I'm trying to describe here. So yes, a new assessment. Let's click on yes, a new assessment, and you're going to have all these items here populate. This is our full assessment. So evaluation date, we already put it in on the first tab. You can see it. You can either change the date or update. Medical history. Now, as we go through these tabs and press update on the bottom, the next tab is automatically going to open up. You see over here it says jump to. You can either change it and go down or up, but if you don't press anything, it's going to automatically populate the next tab to fill out this assessment. So right now, brief general narrative. What we want to do is you want to offer a brief narrative of the patient's medical history. We're just trying to set the patient up. This is our patient. This is their diagnosis. This is their limitations, just to give us a brief introduction to our patient. So over here we're going to write, John is a 6'9" male, presents with status post CVA with left hemiplegia. What other conditions does this patient have? He's got impaired trunk control, limited endurance, what's with our patient? Is he ambulatory at all? Is he able to weight shift? So he's got inability to initiate gait. Let's fix that. How's his coordination? Impaired. Impaired coordination, non-ambulatory, and requires assistance with all transfers, period. Any other diagnoses that we know we can include as well? Patient has COPD, CHF, fib, anything that pertains to the patient's overall decline in function, muscle atrophy, arthritis, any sort of diagnoses and limitations you want to put in. Very important to note, Medicare and other insurances as well, they want to know the patient's limitations, but they also want to know the etiology of the limitations. They want to know if the patient had a stroke, did the patient is a spinal cord injury, what happened to my patient here, why are they so weak, What is the cause? It's just old age, inactivity, muscle atrophy, rheumatoid arthritis, any sort of diagnosis, and we need to link the diagnosis to the limitation. If a patient had a stroke and then they were doing fine, they had a stroke 10 years ago and they were doing fine, they got all their muscle back, they did fantastic therapy and they're doing great, and then COPD, they contracted COPD and they had a fall, and then they were bedbound for a while, and now they have, the lack of the inactivity has caused a lot of muscle atrophy and they're very weak. We're not going to write, the patient had a stroke and therefore they're very weak. This is not why. We want to know what the diagnosis is that has caused the limitation. So a scenario like that, technically the patient will not qualify for a Group 3 power chair because the weakness is not due to a Group 3 qualifying diagnosis. In our scenario with John Doe here, we're talking about a patient who recently had a stroke, which resulted in left hemiplegia, impaired trunk control, limited endurance, and inability to initiate gait. This sort of impaired balance and impaired coordination. We're directly linking it. It's important. Medicare always wants to know the etiology of the patient's limitations. This is my patient's current status. This is why they need equipment, but how did this start? Where's this coming from? What's the diagnosis that caused this? Now we'll go down history and progression, any information we can put in, any recent surgeries, how's the patient's cardio. So our John here is okay, but if the patient had COPD or CHF, you want to put that in over here, respiratory concerns, is he bent? Any sort of information we have in this regard, you want to include it and press update. We're going to go into client background. Now, this is a really important part of your MyForms. This part of the assessment, the reason for the referral, your patient goals, and your caregiver-specific goals. This is where we're going to get a big portion of our qualifying reasons of what we're trying to do for this patient, why they need it, why we're giving it to them. So when we go into reason for referral, we're going to write motorized wheelchair assessment if they're requested for a motorized wheelchair. Then we're going to go straight into, again, always back to the MRADL. So we want to identify it right at the get-go. Our patient has been referred to us for a motorized wheelchair. Why? Patient is status post CVA and unable to get around his home for ADL care. As in getting from his bed to his kitchen for meals. Very important. We just identified a specific activity of the ADLs in the patient's home. This is our MRADL, the patient's unable to accomplish. So we have to write that we're here for a wheelchair assessment. The patient has an ADL in his home. He cannot accomplish. That's a very crucial part of the assessment. Now, we're going to right away eliminate less expensive equipment. Patient is non-ambulatory. We just went ahead and eliminated our cane and walker. Why can't the patient use a cane and walker? The patient is non-ambulatory, unable to initiate gait, it's a high fall risk, and is therefore unable to use a cane or a walker. Now we want to discuss our next less expensive equipment. Item number 2 is going to be our manual wheelchair. So patient is unable to self-propel a manual wheelchair. We tried him greater than 5 feet. Due to probably put those due to CVA with left hemiplegia. He's got the impaired trunk control. We said he has impaired coordination. what are the issues what other issues does our patient have that is causing him the inability to self-propel? He's got limited range of motion. When trialed, the patient was unable to self-propel. A lot of this may sound repetitive, but it's important that we have the specifics officially spoken out directly. So you can't propel greater than 5 feet due to CVA, but want to write when trial the patient was unable to self-propel the manual wheelchair greater than 5 feet. Our next item is going to be our scooter. So why can't our patient use the scooter? Well, a patient has left hemiplegia and poor trunk control. The odds are they're unable to sit on the chair, sit upright, and reach the steering tiller. So we're going to eliminate the scooter now as well. So patient is unable to use a scooter secondary to poor trunk control and left hemiplegia. Patient is unable to maintain posture on scooter or reach steering tiller to safely operate a scooter. So we now went ahead and eliminated our scooter. So just so we understand what we're doing here, reason for referral is a wheelchair assessment. We identified the ADL, we eliminated a cane, we eliminated a manual wheelchair, we eliminated a scooter. Now we're ready to say what the patient is eligible for. Patient requires a motorized wheelchair for ADL care in his home. Important that we attest the patient is able and willing to operate a power wheelchair. Period. That concludes the reason for the referral. We want to get our reason for referral and just go straight, make sure we took care of our necessary components to make sure we're justifying the chair properly. Now we'll go through more parts of the assessment and we'll get a more greater objective information about the patient and so on. But let's go into the next tab, patient goals. Our primary goal is going to be independent mobility. Any other goals? Can the patient weight shift? We want to be able to perform pressure relieving activities. We want to increase seating tolerance. Is the patient having a lower extremity edema? We can address that as well. Want to manage tone. Anything we want to do for our patient, we can put it in over here. Caregiver specific goals. Now, if we were recommending a manual wheelchair, we would have stopped by, I'll do that in the next clip. This is how we do it. This is going to be assessment D6, C1 for a motorized wheelchair.